meeting. Okay. So welcome to today's TAPS seminar. Thank you all for joining us. So before we begin, just a quick bit of housekeeping. Reminder for those joining online, keep your microphones muted during the presentation. We'll have time for questions at the end. So either I'll add your questions to the chat and I'll read them out, or raise your hand if you're in the room. Yeah, just to note, we're recording it. So if you do speak during the session, you may be on the recording. And many of you have already signed up to our mailing list to hear about future TAPS seminars. But if you haven't and you'd like to be added, please either add your email address to the chat, or you can send an email to me and I'll add you to that list. So today we're delighted to welcome Professor Penny Whiting from the University of Bristol. Penny is a Professor of Clinical Epidemiology, co-director of the Bristol TAG and co-director of the BEST Group. She has 25 years experience in evidence synthesis across a wide range of study designs, including trials, observational and prognostic studies, but with a particular expertise in diagnostic reviews and developing robust quality assessment tools. So today, Penny is going to be talking to us about the new QUADAS 3 tool and guide us through a worked example to demonstrate how it should be applied. QUADAS has been the most widely used tool for assessing risk of bias and applicability in diagnostic test accuracy studies, and QUADAS 3 represents the third iteration of the tool, developed using feedback from users, recent methodological advances, evaluations of QUADAS 2, and findings from piloting. So if you're ready, Penny, I'll hand over to you, and we look forward to your presentation.
Great. Thank you for the introduction, and thank you for inviting me to come and speak to you today. So I'm going to introduce you to QUADAS 3, which is an update to the QUADAS 2 tool to assess risk of bias and applicability concerns in diagnostic test accuracy study. And I'm presenting on behalf of the QUADAS 3 team, which also includes representatives from Birmingham. So we've got Claire Davenport, who I think is on the call, and John Deeks is also involved in the steering group. So as a bit of background, I'd expect a lot of you are familiar with the QUADAS 2 tool. That was designed to evaluate risk of bias and applicability of test accuracy studies, and it's probably the most widely used risk of bias tool in diagnostics test accuracy reviews. And whilst feedback on QUADAS 2 has generally been positive, we did identify some areas where improvements were required, where we could improve the tool and also move forward with more recent developments in risk of bias tools. So the aim today is to introduce you to QUADAS 3. I'm going to very briefly outline the methods that we use to develop the tool, but then spend a bit more time taking you through the new tool and taking you through a worked example to show how to apply it in practice. So development steps. We had 3 broad steps in the development of QUADAS 3. The first step was identifying evidence. The next was a face-to-face group meeting of the steering group. And then finally, a lot of iterations going through piloting and refining different versions of the tool until we got to the final version that we were happy with. And across these 3 different steps, there were lots of regular meetings of our core group, lots of discussions, trying to think about how we respond to the evidence, how we can improve the tool, taking on feedback from piloting and going through lots of different iterations. So we used a variety of different sources of evidence as a first step for the update. We looked at the modifications made to QUADAS 2 for the Cochrane Handbook. They were mostly fairly minor, but there were some modifications that we wanted to incorporate into QUADAS 3. We looked at developments in more recent risk of bias tools, so things like answering signalling questions, how to come to an overall domain level risk of bias rating, just more the structure of the tool rather than the contents of the tools. We then had a look at methodological studies that have evaluated QUADAS 2. We looked at published systematic reviews that have used QUADAS 2 to see how they'd used it and whether they'd made any modifications. We then did a web-based survey of review authors that used QUADAS 2. And lastly, looked at guidance from HTA organisations. And this process started back in about 2020, I think, around the time of the COVID pandemic. So other things obviously popped up there, so we came back to it, I think about 2023. And one of the first steps after we'd collated all this evidence was a meeting in London just before the Cochrane Colloquium. And that was a face-to-face meeting attended by almost all of the members of our steering group. And in that meeting, we discussed the findings from step 1, so what the evidence had shown us. We had to think about the scope for QUADAS 3, what do we want it to encompass, were there specific differences we wanted to think about compared to QUADAS 2. We had quite a bit of discussion about applicability and whether we should incorporate that into QUADAS 3, should we consider that differently, and how best to approach applicability more generally. We also had a look at the feasibility of algorithms for arriving at domain level ratings. And we spent some time trying to apply that to an example domain, but in the end, we decided that that was just going to make the tool too complicated to be able to cover all the different situations you encounter in a diagnostic accuracy study. And then we did some work in small groups to end up with a very first draft of the tool. And that draft was further refined through lots of different stages. I think we started with version 0.1 and ended up with version 0.14 before we got to the final version. We went through a series of piloting exercises. We had the steering group do some piloting on a set of 5 papers that were taken forward and are now worked examples to show you how to use the final QUADAS tool. We had a workshop at the Global Evidence Summit in 2024. We did some Think Aloud interviews. We got people using QUADAS 3 in their actual systematic review and providing us with feedback. And all of this gave lots of helpful feedback that ended up in the final version of the tool, which was agreed with our steering group. So this is what the tool looks like. It initially might seem a little bit more complex compared to QUADAS 2, but I think it's also much more useful than QUADAS 2. So the first phase is to state the systematic review question. We then define the ideal test accuracy trial, draw a flow diagram, identify the accuracy estimates to assess for risk of bias and applicability. Then phase 5 is the main body of the tool, the main assessment of risk of bias and concerns regarding applicability. And we've now also got a final formal overall judgment section. Important to note, though, is although there's lots of phases, they're not all done for each set of estimates. So the phases 1 and 2 are just done at the review level, so you only have to do those once for your review. The phases 3 and 4 are done once per study. So a key difference for QUADAS 3 compared to QUADAS 2 is that at QUADAS 3, you just assess the overall study for risk of bias and applicability concerns. With QUADAS 3, you decide what estimates you're going to include in your systematic review, and you assess each of those estimates for risk of bias and applicability. So that you need to decide which of the estimates you're going to assess as part of the tool. And then the last 2 stages, 5 and 6, they're done at for each selected set of estimates. So I'm going to take you through each of these phases in a little more detail, and I'm also going to use a worked example to take you through. So if you want to have a look at the paper, you can scan the QR code there to access the paper, but you don't really need to do that for the purposes of what we're doing today. It's just if you find it helpful to see the paper. So the paper is about rapid dipstick assays for diagnosis of typhoid fever. So the first phase of QUADAS 3 is to state the systematic review synthesis question. So if you've used QUADAS 2, you'll be familiar with it. The first phase there is to define the review question. So by synthesis question, we mean each question that a specific synthesis in your review is going to address. So a single review might address more than one synthesis question. And so the first phase is to specify these with sufficient detail. So for our example study, so we have a sort of theoretical systematic review we're conducting here. So we've come up with these questions that we'd be addressing in a systematic review, looking at dipsticks for diagnosing typhoid infection. So we've got the first questions: what's the accuracy of the dipstick testing for diagnosing typhoid infection in adults with symptoms suggestive of possible typhoid in a community setting? So we've covered the index test, we've covered the target condition, and we've covered the population as part of our definition of the synthesis question. We've got a second question here because these dipstick tests can also detect paratyphoid, but that's a slightly different target condition if you're looking at typhoid or paratyphoid. infection. So that would require a different synthesis to answer that question. Phase 2 is quite a new concept for QUADAS 3. We ask you to define the ideal test accuracy trial, so the ideal hypothetical trial that you could conduct to answer the synthesis question. In the guidance document, we've got some general features of the ideal test accuracy trial for you to think about, but we ask reviewers to define that specifically for each synthesis question that they've identified for the review. So it's the ideal trial to address each synthesis question. And deviations from this design have the potential to introduce bias or affect applicability. And it forms a formal part of the applicability assessment. So when we're assessing applicability, which you'll see more clearly when we move into the domain levels, we're referring back to this ideal test accuracy trial. So here I've got the ideal test accuracy trial for each of those 2 synthesis questions that we've defined as part of phase 1. I'm not going to go through this in detail, and I realise the font's probably a little bit small to read. We have got these worked examples up on the QUADAS website if you want to have a little more detailed look at them. But you can see here we're defining the different components, so the objectives. So for one, we're looking at the accuracy of dipstick tests as an initial triage test for deciding whether to start treatment and seek confirmatory testing as part of a community typhoid detection programme. Whereas for synthesis question 2, we're also looking at paratyphoid in addition to typhoid. So then we think about what the participants would look like. So it's consecutive enrolment of suspected typhoid patients, and we're defining what we mean by suspected typhoid patients there. And it's in a community setting is important for this specific synthesis question. And then we've got some detail about the index test. We've got detail about the target conditions. So what is it we're trying to detect, but also what would we consider an acceptable reference standard? And then lastly, we've got some details about the analysis. Phase 3 will be familiar to those of you that have used QUADAS 2 in that it's the same as we used to ask for in QUADAS 2, which is to draw a flow diagram. And drawing these flow diagrams is really helpful for trying to unpick exactly what's happened in the study, who's received what tests, where have people dropped out, where are we missing data. So for this particular study, we've got enrolment from 4 different settings, and the reference standard is different in one of those settings than in 3 of the other settings. So we've reflected that in our flow diagram. And then we worked out what the 2x2 data are, and we think that everybody that's enrolled in that study has ended up in these 2x2 tables at the bottom here. So that's helpful to see. We've also got, as well as a sort of prospective cohort, we've also got a set of controls. So it's sort of a 1-gate design in that it's got the cohort studies enrolled going forward, but you could also include this 2-gate design of people with known conditions that are not typhoid fever. So it's quite, in some ways, quite a complicated design. There's lots going on in this study. So our next phase is to identify the numerical accuracy estimates to assess. So this is also something you'll be doing as part of your data extraction, is thinking which estimates do I want in my review? And this really formalizes that process of linking those estimates back to the synthesis questions that you defined at the start. So that's the first thing you're asked to do in this table, is to identify which estimate relates to which synthesis question. And then all the other information is just to identify, so you know which estimate you're talking about and how the estimates are different. And what's also quite helpful is the very last row tells you which QUADAS 3 domains will be assessed. So for your first estimate, you'd assess all the QUADAS 3 domains. But for estimates 2 and 3 and subsequent estimates, you only need to assess the domains that you'd expect to be different. So we're not getting you to fill in the same information multiple times. So supposing you've got 2 index tests, you'd only need to fill in the index test domain for each of the estimates that come for each different index test, because everything else you might expect to be the same, unless there's any reason to think the other domains might be different. So you can specify that at this stage. Okay, so as I said before, this study is quite complicated in terms of trying to decide which estimates you want to include in your review, because you can get all these different estimates of sensitivity and specificity from this single study. So we've got 3 different potential populations. We could just go for those enrolled at the Dr. Karyadi Hospital because they're getting a better reference standard. You can go for patients enrolled at district hospitals alone. You could separate those out and have district hospitals and Dr. Karyadi hospitals. And then you've also got the negative controls, but they're introducing a sort of 2-gate case control design. So we probably want to exclude those as likely to overestimate accuracy if you include them. So here we've got the sort of list that we could possibly include, and then we've sort of thinking about, okay, so for our review, for those specific synthesis questions, which are the estimates we want to include? So we've decided there's potentially 3 estimates we might be interested in. So there's taking people enrolled at all 4 hospitals, so the Dr. Karyadi and the 3 district hospitals, with typhoid fever as the target condition. We might also just want to take the data for the Dr. Karyadi Hospital because that's sort of our best data. That's used the most appropriate reference standard. But there's very few people without typhoid fever in that population. So they're also likely to be a slightly different population, and we'd get very wide confidence intervals for our specificity estimates. So you've kind of got a trade-off between having data with a better reference standard or more data from taking all the typhoid patients, and possibly a more representative sample of patients in that group as well. And then we're also interested in the typhoid or paratyphoid, but for that we'd take all the typhoid patients because we've only got 2 patients without either typhoid or paratyphoid, so we wouldn't get very good estimates of specificity from that data set. So we sort of mapped out all the ones we possibly could take, and then we've selected those 3. This is probably much more complex than you'd need to do for most studies because you'd very rarely get this many estimates of accuracy from a single study. But that's just sort of illustrating how you might encounter this as an issue. Okay, so what we do then is we take those 3 estimates we've identified, and then we fill in this information to help us know what these estimates are, what do they relate to, and how might they be different. So, as I said before, for estimate 1, we'd fill in all the QUADAS domains. For estimate 2, we'd need to fill in participants and target condition. Again, we'd expect the index test and the analysis domain to be the same. The participants would be different because they're just coming from this single hospital. The target condition is going to have different answers because we've got the different reference standard. We've got blood and bone culture here, whereas the district hospitals are doing blood culture only. And then estimate 3, it's just the target condition that's going to be different because that's the typhoid or paratyphoid, whereas we'd expect participants to be the same as estimate 1. So you've only got to fill in that domain for this extra estimate, the 3rd estimate. Okay, so that's sort of all the background work to get you to the main body of the tool where we're assessing the risk of bias and applicability concerns. So I'm just going to give you some overview of what a domain looks like, the general features of the domain, and then we'll go through each domain individually, looking at them in more detail and working through the worked example. So this is what a domain looks like. Up at the top of this participants domain, we've just got clarification on handling of dropouts because it's often unclear which domain to cover those in. So we've just got some guidance here that says if participants dropped out or were excluded from a study because they did not receive the index test and or the reference standard, it should be handled in the analysis domain. We're in the participants domain, we're just interested in who's getting actually into the study, who's being included, not who drops out once they're included. So we've just clarified that up at the top. We've got these what we call support for judgment sections, and they're a little bit more structured and link more clearly to the signalling questions, which are these questions down here, 1.1, 1.2, 0.3, etc. So we're describing how participants were selected, we're describing any restrictions to enrolment. So we're taking out that information that we're going to be using to answer the signalling questions. Compared to QUADAS 2, we've changed how those signalling questions are answered, and this is more in line with other tools you might be familiar with, like ROPE2, Robbins I, ROBIS, PROBAST. So we've introduced this probably yes, probably no option. And we found from other tools that people might not be sufficiently confident that they're happy answering a yes, but if they can answer probably yes, that will push them towards an answer. And in practice, the yes and probably yeses are interpreted the same way. And it's much more useful to have a yes or a probably yes than a no information. And actually, that's also a little change we had unclear as an option before, whereas now it's no information, because we only want you to answer no information if there really isn't any information to be able to answer that question, trying to push towards an answer, because that's more useful in judging the overall domain level risk of bias. So signalling questions are sort of factual questions that help us judge risk of bias. They're all phrased so that yes is a good thing. If all questions are answered yes, then your overall risk of bias is low. If any is answered as no, or probably no, or no information, then you've got to think about, is that sufficient to push your domain level rating to a high or insufficient information? There are some slight changes to the signalling questions. Some will look familiar, some will look familiar but slightly different in that they've been reworded a little bit, and some are completely new. We've changed the overall domain level rating to a statement. So it's the risk that the selection of participants has introduced bias. Before it was a question, and the answers didn't really make sense as a question. So it makes more sense as a statement. This is an important change. We've added a rationale for judgment, and that's a really helpful change, I think. So here we answer our signalling questions. Based on the answer to the signalling questions, we judge the risk of bias. And here we explain how we've got to that judgment. So if everything's answered yes, we could just have something like no concerns. But if we've got identified an issue, we want the summary of what that issue is and why we think that's introduced bias into the study. And that's also quite helpful at the end when you're trying to bring your QUADAS assessment or your risk of bias assessment together, is you've then got a clear summary of what the problems are in each domain for each study. At the bottom here, we've got our applicability concerns. And the phrasing here is a little different than it was before. It's concerned that the included participants do not match those in the ideal test accuracy trial. So here we're referring back to that ideal test accuracy trial that we defined in phase 2. So there's a clear link back to the test accuracy trial. And we also now have a new section on the rationale for judgment, the same as we do for the risk of bias assessment. So some things, if you're familiar with QUADAS 2, are quite similar, but there are some changes as well. Okay, so I'm now just going to work through the participants domain for that trial. So the first question here is describe how participants were enrolled. So have we got a single gate, or what we sometimes know as diagnostic cohort or cross-sectional study design? So it's a group of participants in whom the diagnosis was not yet known. Or is it a multi-gate case control design? So remember, this is done at the estimate level. So although at the study we've kind of got this mixture of a single gate, multi-gate design because of those negative controls, the estimates we've selected aren't based on those negative controls. They're just based on the single gate design. So we've got a single gate design, but they've got 3 different groups of participants. So we've got the suspected typhoid fever admitted to Dr. Cariadi. We've got the suspected typhoid fever from the district hospitals, and we've got those controls, the alternative conditions, but we're not using, our estimates aren't based on those. We've got a question on describe whether enrolment was prospective or retrospective. And it's not clearly described, but the description suggests that it's likely prospective. And is there any more detail on how participants were selected for enrolment, whether that was consecutive or random? And that we're lacking information there. And also the last bit is about restrictions to enrolment. So no information. Oh, we've got the wrong answer in that bit there. But, so I don't think we had any information on restrictions to enrolment. And then for each estimate that we've defined that we need to assess this domain for, we have that assessment. So 1 and 3 we've highlighted at the start were going to be the same for participants, and 2 is different because it's the Dr. Cariadi Hospital. However, actually the answers have ended up being the same. So we have got a single gate design. We don't know for definite, but it seems like it's a prospective study. What we don't have any information on is whether we've got consecutive or random sample of participants, or whether the study group's representative of the intended use population. So this is a slightly tricky question, actually, whether it's representative of the intended use population, because it starts to sound a bit like we're merging into applicability. But here we're thinking about the intended use population as defined by this particular study, rather than what we've defined for our ideal test accuracy trial. So given the study, how they want to evaluate or who they want to evaluate the test in, have they recruited a representative sample of that group? But we haven't got very much detail on who they've recruited or how they've recruited them here, so we've answered that as no information. And then you can see this bit at the bottom is really helpful, the rationale for judgment. So we've got the main design as a one-gate design, consisting of patients with clinically suspected typhoid, although these were enrolled in 4 groups at 4 different hospitals. We haven't got any information on the criteria for clinical suspicion of typhoid, whether a consecutive group was involved or whether any specific groups were excluded. And it's also not specified whether participants were prospectively enrolled, but the description of the study suggests that this was. It's therefore difficult to judge this domain for this group of participants. So for that reason, we've answered it as insufficient information. Then for the applicability, we're referring back to our ideal test accuracy study. We've done it again separately for 1 and 3 and for 2 because they're slightly different populations, but for both we've ended up with high concerns for applicability. And that's because patients in this study were people with a high suspicion of typhoid seen in a hospital setting, in whom it appears most other infections have been ruled out. So the prevalence of typhoid is much higher in this study population than in the community, maybe more severe disease as well. So we have high concerns that the estimates from this study would apply to the population that we're interested in, the population that we've defined in the ideal test accuracy trial. So moving on to the index test domain. This is fairly similar to what we had for QUADAS 2. What we have got is the addition of the first question about conducted and how the index test was conducted and interpreted. QUADAS 2 didn't actually have anything about how the index test was performed. So again, the descriptions up at the top link quite clearly to the signalling questions. So we are asked to describe the index test. So it's a newly developed rapid dipstick assay. And we've got different results for -1, +2, +3, and 4 based on staining intensity, judged by comparison with a coloured strip. Describe whether the index test was conducted and interpreted according to recommended instructions. And I don't think we had a lot of detail, but generally the study suggests it probably was performed in line with recommended instructions. Describe what information was available to those interpreting the index test. So we haven't got any information on that. And if a threshold was used, describe how this was selected. So the threshold was pre-specified and results were available for all thresholds. So working through our signalling questions. So this time we haven't got to answer this domain separately for any of the estimates, because there's not going to be any different bias estimates for those different estimates. Bias issues, sorry, for the different estimates. So we think that yes, the index test was conducted and interpreted according to recommended instructions. We don't have information on whether the index tests were interpreted with knowledge of the reference standard results, but it's a rapid dipstick test, the reference standards culture, so it's likely that you'd have the tests before you'd know the test results before you'd know the culture results. Were the index test results interpreted with the same information as would be available when the test is used in practice? We don't have any information on that. And the threshold was pre-specified. So overall, we haven't really picked up any particular issues. We've just got a lack of detail on the information. But we've judged this domain overall as low. So we've got no information available on whether the reference standard results were available to the person interpreting the test, but the dipstick result is likely to be available before the culture results. Threshold was pre-specified, little information how tests were interpreted. we have put a note saying it could be reasonable to judge the domain as insufficient information because there is some subjective degree of subjectivity in interpreting the test because it's based on staining and referring to a coloured strip. So you could theoretically think that might be able to be influenced by external information. So it's a bit of a judgment here as to whether you think that's a problem or not. Okay, so moving on to domain 3. Oh, sorry, no, the applicability. We've got high concerns regarding applicability here, referring back to our ideal test accuracy trial. Although the test itself matches that in the research question, there's no information on who interpreted the test. And this study was conducted in a laboratory rather than a community setting, and we're particularly interested in whether the test can be used in a community setting. So we've got high concerns here. Okay, so now moving on to the target condition. This domain is probably the biggest change. This one and the next domain are the biggest changes to QUADAS 2. So this was the reference standard domain. We've now called it target condition because it's all about how you're assessing and defining the target condition. Some of the questions that we had in the flow and timing domain for QUADAS 2 have moved into this domain because they really are about how we're defining the target condition. I'll take you through the domain in more detail with our worked example. So we're defining the target condition, and we've got the different target conditions for estimate 1 and 2 and estimate 3. So the typhoid fever alone, or the typhoid caused by typhoid or paratyphoid. Describe how the target condition was assessed, what reference standard was used, and how it was conducted and interpreted. So here we've got that issue of the 2 different reference standard, depending on where the patient was enrolled. So we've got suspected typhoid, the Dr. Cariadi Hospital, where they've got them more reliable bone and blood culture, with either positive being considered as a positive, or the district hospitals where we've just got the blood culture. And we haven't got any information on whether culture results were interpreted blind to dipstick test results. There's not a lot of detail on how the culture was done. And we also have a little bit of information on time interval between index test and reference standard. Samples for culture for the dipstick assay were collected at the day of admission to hospital, and we assume that's probably the same point at which the dipstick test was done. So now we've got 3 different estimates here. Each one needs to be assessed separately. Estimate 1 and 3 are the same, except for one's assessing typhoid and the other one's assessing typhoid or paratyphoid, whereas estimate 2 is from just the Dr. Cariadi Hospital. So we've got the more reliable reference standard. So if we look at the questions here, we've got, does the reference standard adequately identify those with and without the target condition? And we've got that as no for estimates 1 and 3, but yes for estimate 2, because that's come from the more reliable reference standard of the bone and blood culture. Was the target condition assessed in all participants? Was the target condition assessed in the same way in all participants? Did the reference standard avoid incorporating the index test? We've got a question about how the reference standard was performed. Were the reference standard results interpreted without knowledge of the index test results? So that's similar to the index test question about information available. Here, this is another new question, is if the reference standard threshold was used, was it standard or pre-specified? Because as well as having a threshold in the index test, you often have to have a threshold for the reference standard. And then we've got the time interval between the index test and reference standard question, which was part of the flow and timing domain for QUADAS 3, but it's all about the target condition and how that's defined, so it does fit much better here. So overall, we've got high risk of bias for estimates 1 and 3 because they're based just on the blood culture, not the more reliable blood and bone and blood culture. And for estimate 2, we've got to come up with insufficient information because there's not a lot of information about the reference standard and how it was performed and what information was available to the person interpreting the reference standard. So we've got our rationale for judgment, and we can see we've got slightly different rationales for the estimates 1 and 3 and for estimate 2 because of the different ratings. We've got the applicability of the target condition. This is we've had a lot of discussions about what constitutes applicability for the target condition, and we've written a separate paper on this, which might be helpful if you're going to be using QUADAS 3 to try and unpick when you have concerns regarding the target condition. So the question here, or the statement here, is the concern that the target condition as defined by the reference standard does not match the ideal test accuracy trial. So we need to be very specific in our ideal test accuracy trial about what the target condition is we're trying to detect and whether the reference standard is going to appropriately detect that, or whether it's detecting something different. So for estimate 2, the Dr. Cariadi patients, where we've got the blood and bone culture, the target condition and reference standard match those specified in the target trial. So we've got low concerns regarding applicability. But for estimate 1 and 3, although the target conditions matches that specified in the ideal test accuracy trial, the reference standard does not. So we think that using only blood culture as opposed to blood and bone culture means that some cases of infections are likely to be missed. And they might be those that are harder to diagnose, meaning the group of participants classified as having typhoid or paratyphoid will not be the same as that specified in the target trial, and therefore we've got high concerns regarding applicability. Okay, so our final domain is our new analysis domain. So this was the flow and timing domain, but we've moved a lot of what we had in the flow and timing domain into domain 3 about the target condition. And what we've left with here really is all about analysis. And again, I'll take you through that with our worked example. So first of all, we've got to describe any people that were enrolled in the study that didn't end up in the 2x2 table. And that's where your flow diagram is particularly helpful to try and unpick that. And here we've got all our participants that were enrolled in the study are included in the analysis. We've got a question about the unit of analysis. So for this study, it was pretty much always going to be participants, but you do see a lot of studies where you might have participant samples, specimens. And so it's important to specify what that is. We've got a question called describe any non-standard statistical analyses used to generate estimates of sensitivity and specificity being assessed. So if you're doing anything that isn't just based on your 2x2 table to get to those estimates, and in this paper is straightforward, and most probably will be that you assessed, and that there's no complex analyses, and we haven't got any missing data. So here, these support questions link directly to our signalling questions, and we haven't got any concerns here. We've got all participants entered into the analysis, haven't got any missing data. The unit of analysis matches what we've defined in our ideal test accuracy trial, and we've just done simple calculations to get to sensitivity and specificity, so they're calculated appropriately. So our final phase is phase 6, which is our overall judgment, and it's really fairly straightforward in that you pull through the judgment for each of the domains. What's new, an important formal part of this is that you also bring the rationale for judgment through, which then allows you to have a single overall rationale for judgment, which I always report in my main tables, reporting the results of the QUADAS assessment. And probably easiest if I just show you an example here with our example study. So we've got our 3 different estimates. We've pulled through our judgments for each domain, and then we've had a rationale for judgment, and we've just maybe simplified this to pull out what the real key issues were for each domain. We haven't got quite as much detail as we had within the individual domains. And then if any one domain is at high risk of bias, the study's at high risk overall. If all domains are at low risk of bias, then, sorry, not the study, the estimate is at low risk overall. And if we've got some low but also some insufficient information, then overall it's insufficient information. And then we can also pull through. So for estimates 1 and 3, it's really the main issue here is the hospital's only using blood culture and a lack of detail on how participants were enrolled. And for estimate 2, that's the lack of detail on how participants were enrolled and some lack of detail around the reference standard. So we've pulled that through, we've got that judgment. So we know that overall, 2 of our estimates are at high risk of bias, one's insufficient information on risk of bias, and this is the reasons for that judgment. And I think that's a really helpful change to the tool. Similarly, for applicability, it works in exactly the same way. So here, they're all at high concerns regarding applicability. And the main problem is the study being conducted in a hospital rather than a community setting, with results interpreted in a lab rather than the community. So we've got a clear, simple summary of the concerns regarding applicability there. So that was the QUADAS 3 tool. I've just got a little summary of the main changes compared to QUADAS 2. So the major change is assessment of risk of bias and applicability concerns at the estimate rather than the study level. And I think that's a really important, really helpful change, because you do have different concerns for bias and applicability for different estimates that come from the same study, as we've just seen from that example study. The potential to have multiple synthesis questions and to link these clearly to the estimates that we're assessing. The ideal test accuracy trial is a real new stage to QUADAS 3. It does make it quite a bit more complicated. It means we're using QUADAS 3 in our second review that we're doing now, and that having a lot of thinking, a lot of discussion at the start is really important. And then once you've had that discussion and understood what you want the ideal trial to look like, you've developed that then into guidance for how to answering your specific signalling question and domain level questions. That really helps to understand what you want, what estimates you want to be extracting, and to do a much better job of your risk of bias assessment once you get to that stage. And then the formal section for the overall judgment, I think, is also really helpful, particularly for thinking about reporting and incorporating those results into your review. So we've got some more changes to domains and signalling questions rather than structural changes. So patient selections being changed to participants, reference standard to target condition, flow and timing replaced by analysis. You've seen we've got some new signalling questions and wording of more challenging signalling questions. The change to the answers to the signalling questions. So we've got the addition of the probably options. Domain level judgments, actually I didn't mention this earlier, but we had unclear as well for both the answer to the signalling questions and the domain level judgments in QUADAS 2. We've replaced this with insufficient information, so that pushing towards a judgment unless there really isn't enough information to make that judgment, not just because you can't decide on the information that's there, which often happened with the unclear judgment. The introduction of the rationale for judgment, phrasing of the domain level judgments as statement rather than questions, and the focus of applicability judgments on the synthesis question and the ideal test accuracy trial. So I think that really helps the applicability assessment. It makes it much more transparent and clear how to apply that. Changes we considered but didn't introduce. So the use of algorithms, I mentioned before, we just didn't think we could make that work with the complexity of the tool without making it even more complex, and we didn't want to do that. We looked at integrating QUADAS C more formally into the tool, but we decided again that would make the tool too complicated, and often you don't need the QUADAS C components. So we've got some guidance on how you can use QUADAS C alongside QUADAS 3 if you're doing a review comparing multiple index tests. And that will be a next step in the work that we're doing, is to formalise that and to consider whether we need to make any changes to QUADAS C. We also looked at moving from signalling questions, so where you're asking, at the moment they're all asked as questions, to statements, and we explored that in the piloting, and there wasn't really a strong preference, so we decided to stick with the signalling questions, which is what people are more familiar with. Okay, so where can you find QUADAS 3? So the best place to go and look for information on QUADAS 3 is our website. So on the website you'll find the tool, the explanation and elaboration document. We've got a set, I think, of 5 worked examples, and we're just starting to work on building some training materials, so some short introductory videos covering the different domains and covering the overall structure of QUADAS 3. So trying to get some formal training on there. We'll probably also put the recording from this talk up there as training, as an introduction video to QUADAS 3. And we've got 2 papers that have been published on QUADAS 3, the main paper and then the very detailed E&E paper, both of which were published in Annals of Internal Medicine in February, but you can link to them from the QUADAS website. It may look like you've got to log in to get to them, which is true. You have got to log in, but you can just create a free account and then you can log in and access them. You don't have to pay to access them. They are freely available. So I would just like to finish by just acknowledging the whole QUADAS 3 team, the steering group, and particularly the core group members. We've had hours and hours of discussion to get the tool to where it is now. And that QR code will just take you to the QUADAS website if you want to find out any more information. So thank you very much. I'm very happy to answer questions. Oh,
thank you very much, Penny. That's great. So we've got just over 10 minutes. If anybody's got any questions in the room or online. Yeah, Jack.
Hi, Penny. Jack Dennis here. Thank you for your presentation. It was really helpful actually to go through it. I've read the paper obviously, but having you go through it like that was really helpful. And I really like the changes to the tool. I think it's going to help people, try to force people to think through the methodological issues about accuracy studies more carefully than perhaps they might always necessarily have done in the past. I just wondered about the kind of extra complexity which you've acknowledged, and how that translates through to reporting the QUADAS 3 results in a systematic review, where obviously you've got many studies. Have you had, can you comment on any challenges in how to present the results?
So I think having that overall rationale is actually really helpful for how to present the results, because you can present, so I usually do a table where I've got the domain level answers and then that rationale for judgment in a final column. So that's useful. I suppose in terms of additional complexity, when it comes to reporting, it's not the earlier stages because they are things you do at the review level mostly. But the actual assessment of domains, you need to report it by estimate level. So you might just end up with slightly longer tables if you've got lots of estimates coming from the same single study. We're just at the write-up stage for the first review that we've used QUADAS 3, and so we haven't sort of tackled it formally yet.
Okay.
I think that would be how it
is. And will you be talking to Cochrane about getting it into RevMan?
We are. We've just started that as well. In fact, some of the team are doing a webinar for Cochrane on Thursday morning, which will be very similar to what we've just covered today. But we're just having those discussions.
Thanks.
Any other questions in the room online? John?
So it's John here. Penny, it's great to see it come to the end of seeing it come together on this. I guess there's a question following on a bit from Jack's question. When we've got to multiple, like you had 3 actual descriptors, what advice are we giving people about what do we do with this when we do a meta-analysis?
So the meta-analysis, it's probably more helpful for the meta-analysis than it was before, because each estimate, you'll decide which estimate you're going to put into your meta-analysis, and each estimate's probably only going into one meta-analysis. So you've got that risk of bias more clearly linked to each estimate.
I guess it's when we present it, is it going to be a bit confusing as to what actually has gone into the meta-analysis? I mean, it's describing it. It's critical in that you end up with potentially multiple meta-analyses from that.
Yes, but I don't think that's any different to what you'd have done previously. We're just trying to link the risk of bias assessment more clearly to what you do in a systematic review. So in a single systematic review, you'll often have multiple different meta-analyses with different estimates going into them. And now we'll have the risk of bias assessment tied more clearly. So if you wanted to put it on the forest plot, say you've got it linked to that specific estimate.
I guess there's a question, sorry, a follow-up question that is that there are some situations where you'll end up wanting to include more than one estimate in the same meta-analysis. So that may be that you've got several cohorts effectively within a paper.
Yeah.
In some ways, it would be better to actually create a new study for that, in terms of thinking through actually how will it work go into the Cochrane meta-analysis setup, because you need a separate entry from it. So that's sort of maybe something we need to work through is where how the advice would be placed for the Cochrane reviewer to make the system work for them.
Yeah, so we use Nested Knowledge online systematic review software, and we've got it set up in there, so it's working quite well. So we define the different estimates, and they've got an estimate tag, and then everything else. Each risk of bias has that estimate tag, so you can sort of link it all back together. It's a bit a bit complicated and has taken some thinking through, but I think we're starting to get it working quite well. So there are ways of doing it, but the whole data extraction process does need thinking through and setting up quite carefully at the start.
Okay, any more questions? Ben?
Hi, it's Bethany here. Thank you for your talk today. It was really useful to hear like the process of how to go through this new tool, and well done to you and the whole team for all your work on this. I just wanted to ask specifically about with the first domain, like participants, and it was statistical bias 1.4, so it was one about the population being representative of the intended use setting population. And I just wanted to see if you had any more clarification about like how that's different to the applicability at the domain. It was quite a tricky,
Yeah, so that question was one where we really struggled to get the wording right, and it's evolved from the question from QUADAS 2 of inappropriate inclusions and exclusions. So what we're trying to get at there is, given the population that they're intending to use the test in, have they excluded any groups or particular participants from their study that you'd want to evaluate the test in, which is a bit different to our question where we're so for example, in that study, they may have been interested in evaluating it in a hospital setting. We just want to make sure they haven't excluded people from the study group that you'd want to use it in a hospital setting. Whereas for the applicability, we're interested in the community setting. So we've got the concerns regarding applicability because it's done in a hospital setting.
Okay.
It's a bit of a subtle difference. We're also working on a paper on difference in how to assess applicability for the participants domain in the same way we've done it for the target condition domain, which will explore all of that in a lot more detail, because it's not simple or straightforward.
All right, thank you.
So I just wondered, Penny, so obviously one of the things introduced here is this ideal test accuracy trial. I just wondered how you anticipated or thought that this might affect how studies are assessed in terms of applicability in practice. I guess what's going through my head is that probably a lot of studies won't necessarily meet that ideal.
No, and we don't expect them to necessarily meet the ideal test accuracy trial. It just gives you a kind of framework to work against when you're doing your assessment, and we're finding it's really helpful to think through as the early stages of your review to get the different stakeholders involved, particularly the clinical experts, to try and really work out what would your ideal trial look like and how are deviations from that ideal trial likely to introduce bias into your study. And actually having a meeting and talking that all through with all the team at the start is really helpful. I did a similar training session on this for our group that's working with QUADAS 3 at the moment. We've almost done all the QUADAS 3 assessments, and we hadn't had this sit down at the start thinking through what the ideal test accuracy trial would look like. We'd had some discussions with clinicians and that had fed into it, but we hadn't all sat down together and thought about what does this look like and what should our guidance look like. And as we did the training and we're talking it through, we were picking up issues that we hadn't thought about, sort of individually looking at it, reading the guidance that we drafted and editing it. So we ended up having to update all our guidance, update the ideal test accuracy trial, and change a lot of the QUADAS assessments that we've done. So having that step near the start is probably really important to really get that really clear and transparent at the start, will then really facilitate doing the assessments as you go through the review.
Any more questions in the room? I will check online. Okay, we don't have any more questions in the room and online, but let's thank Penny again for a very interesting talk. So thank you very much.
Thank you.
And before we wrap up, just to let you know, we have our next TAP seminar on the 9th of June at 1 p.m. again, where we'll be joined by Toby Hackman from Leiden University Medical Centre. Toby's going to be talking to us about his work on developing a clinical prediction model for patients with melanoma, with a focus on modelling decisions and the incorporation of background population mortality using relative survival methods. So thanks everyone for attending, and hope you enjoy the rest of your afternoon. Thanks again, Penny.
Thank you. Bye.